Can you hear me okay?
Yes.
Oh, perfect. To say that am I on mute? Perfect. So this is case review 45, everybody. Another shout out to one of my wonderful student midwives who helped me to prepare this case. Let's get cracking. The maternal history for this lady, she's 27 years old. She is GBS positive. Gravida 1 paranaught with a low risk pregnancy, O positive, booking blood pressure 125/75, booking BMI of 30.5. She's a sickle cell carrier with no allergies and no social or mental health concerns. Late booker for an unknown reason at 16+5. I think there was some kind of delay with getting her a booking appointment, to be honest with you. I think that's the reason why. And her last scan was at 22+4, routine anomaly with placenta posterior high and normal fluid and all of that shebang. So she came into triage on the 29th of the month with query Schrom at 35 weeks and 3 days, with complaints of lower abdominal pain with no PV bleeding. So this is a preterm case for you. Blood pressure 112/76, pulse of 88, resps of 18, sats of 100, and a temperature of 36.6. Dorsreben was started for this lady. I'm assuming the lower abdominal pain wasn't at this point considered to be contractions by the midwives that were working in triage. Because obviously we wouldn't necessarily use Dorsreben when women are complaining of sort of like coming and going pains or anything like that. So baseline here is around 150. And this continues on to the second segment here. And it did not meet after 60 minutes due to no episodes of high variation, no high episodes essentially. SHO plan was to admit to Hope Ward, IV antibiotics due to the fact that she was confirmed Schrom. Review in 24 to 48 hours for induction of labour due to Schrom. Any thoughts on this one? I'll go back so you can see a bit more of it.
Sorry, Cara, I got cut off for the beginning. How many weeks is she pregnant?
Oh, Maya, you're breaking up, my lovely.
How many weeks is she? How many weeks?
Not really sure what's going on here. Oh.
She's asking how many weeks, Cara. Can you hear Cara?
Oh, am I in? Can you hear me?
We can hear you, Cara.
Thank you. I don't know what happened there. My Wi-Fi cut out.
Oh, Maya was asking how many weeks pregnant is this lady?
She is 35+3, Maya.
Okay, thank you.
Perfect. Sorry, did anybody, I don't know what happened to my laptop there, but did anybody say anything in terms of what they'd interpret the CTG?
There is some uterine activity, so I'm assuming maybe there will be some brewing infection under just because of the activity.
Yeah, possibly, or possibly even here as well. The urine sample, I think, had some leukocytes in it and a trace of protein, but obviously she's Schrom, so that kind of makes our urinalysis a little bit more difficult to interpret properly.
Good evening. Is there any cycling later on? Would you mind going one forward?
Not particularly, Dagmar, no.
Okay, so we have preterm Schrom, uterine activity, a base rate of 150. The variability looks within normal, but I can't see any cycling. I do believe the page beforehand, I would have probably been able to say that there's potentially one acceleration, but from the 220 to 250, that looks like one acceleration, but
Yeah.
none of the others are more than 15 beats per minute. So as such, you have an abnormal antenatal CTG. So no cycling, no kind of 2 accelerations in a 40-minute interval. So if you don't use dose Redman, you have to use your common sense, and then this is not.
Absolutely. Do we agree with the plan then? Admit to antenatal ward, give IV antibiotics, review in 24 to 48 hours, and then for induction at 24 hours.
I'm not sure if I would leave it for 24 to 48 hours, to be perfectly honest.
No.
I don't know what your local kind of guideline is, but if you have an abnormal antenatal CTG, that's always my question. Are you waiting to do something, or do you do something to wait for longer? So if you do something and you think that essentially kind of improves the situation, fair enough. But if you're just waiting, what are you waiting for? So so no, I'm not agreeing with the timeline. Sorry.
Yeah,
Perfect.
same here. I would admit her to labor ward and then observe, but I wouldn't admit her to her ward, and definitely not to leave her for 48 hours.
I think as well, sorry, I just realised I couldn't see that beforehand because my computer was funny, but the STV for this was also 4.5. Now, obviously we know that we like STV to be over 4. So it technically is considered normal, no sort of risk of hypoxia here. Although was Dawes Redman used correctly in the first place if she is having some uterine contractions? But yeah, absolutely. Also, I think if this was a 37 weeks or, a term baby, our plan may have been to sort of leave it slightly for longer. However, this baby is 35 weeks and 3 days. So adding the preterm element into that, we do have quite a high risk. We have quite a high risk case now. But that was the plan.
Cara, just to mention, we just recently, like in the last 2 years, changed from 36 or 37, from 34 to 37. So if we were 2 years ago with the same CTG, you would have said 34 weeks induction of labor. So I don't see why in this scenario you would leave.
Yeah.
You are worried. Previously, you were inducing at 34 weeks. We use our common sense and say, no, we are not waiting to 36, 37. We induce.
Yeah.
So I would agree to admit to labor ward and also to more or less see the parameters and everything. And if it doesn't, like make me feel happy to wait, is to induce straight away.
Yeah.
Not even admission only. Admission, induction, and go ahead.
Perfect. Anybody got a different idea as to what they're doing? Anybody sort of agree with this plan put in place? Okay.
I just have one question for Mr. Naguib. At what point in time would you, with a not normal antenatal CTG, essentially not induce anymore? What are your cutoff criteria for clinical scenario in CTG? So just because it's quite helpful to kind of set out your red flags. Yeah.
Yeah. So what we had Dagmar recently. So and this I dated to possibly 6 months or 8 months, something like that. And a lady came 34 and 1, CTG not meeting criteria of those Redmond. Variability was, I would say, crap, to be honest with you, the least I can say. And the lady was feeling the fetal movement, CRP was 50, and still the team thought then the guidance has changed and they wanted to wait to 36 weeks. And on in the morning they sent her for a scan, and the scan said the Doppler is normal. And the when they saw that the scan is normal, they thought we will wait. Uh, by the time they put her back on the CTG, after being reassured, the registrar came to see the CTG, or the lady. The lady had no fetal heart, and the senior registrar at this time looked at the CTG that was seen by the consultant earlier, and actually it wasn't seen by consultant. It was the band 7 who left the CTG to have a deceleration, then removed the CTG. What I wanted to say is, when we were doing root cause analysis, the baby died, of course. We were thinking, like previously, we were inducing at 34 weeks. Just before the guidance has changed, we are doing 36 weeks. Um, I always with the point of, if every single parameter is completely fine, yes, we can continue to 36 weeks. If anything is not right, like this one having no cycling, as you rightly said, Dagmar, I would, yes, we all agree that it is not hypoxic, but can we labor on this CTG? Yes, we can. So I would personally be more inclined to induce directly and possibly put Cento on. And if any signs of choreo, decelerations, and so on, I go to theater. So I don't know whether this is the answer to what you said, or you were asking something else.
No, you replied that absence of cycling is not a reason for you not to go ahead with induction of labor anymore, and there is no kind of such thing as an agreement, particularly when you think about choreo in the world, in the kind of in different units. And so therefore, I just wanted to know where your cutoffs are.
Tara?
Yep, I'm coming. Perfect. So she is transferred to our antenatal ward, and the CTG is restarted within the next sort of 2 hours. She had some bloods taken in triage, HB of 127, platelets 192, and white cell count of 11.2. This is her triage CTG, her Hope Ward CTG. So Dawes Redmond again was restarted. This woman was complaining of abdominal pain again. But yeah, variable D cell there at around 17, 18. CTG looks very similar to the one in triage, I think, but less of the uterine irritability, I think, and a little bit more clear with the contractions. This is it. Continued. Dawes Redmond again did not meet. STV of 4.9. The midwife escalated this to the obstetric registrar on the day, and the plan was made for 4-hourly CTG, but to commence augmentation on labour ward. I'm assuming that was when labour ward were happy to accept the patient. She reports feeling well, fetal movement since triage, but has been feeling mild contractions. The uterus was soft on palpation.
So Kara, just to question, when you said abdominal pain, is this separate from the contractions?
No. This lady, I think, first time mother, first experience of everything, was getting some sort of period like cramping and whatnot. Was getting some cramping and whatnot and assumed it was just a bit of abdominal pain as opposed to sort of the start of labour.
Okay, thank you.
Okay. So care was continued. So that CTG was at around 6 o'clock. The CTG was replaced at 23:40 or 23:35. She had some IV antibiotics administered due to her GBS status. She was moved into various different positions and she was encouraged to drink plenty of fluids. Midnight position was changed again due to the fact that the midwife had concerns with this CTG. And then at 00:27, the CTG was discontinued to show to the labour ward coordinator, of which the plan was to transfer her in an hour's time. I think that was when there would be a midwife available to take her over and continue on with her care. This is her CTG continued now. Dawes Redman again was sort of restarted at 00:30, although at this point there was no major reports of abdominal pain. Baseline still remains sort of 150, 155. And yeah, criteria was met on this one as well. Very interesting. I think that's supposed to say 0116, not 0016. Blood pressure remains stable, pulse is 99, and respiration rate is 17. So, she's transferred over at oath. Pardon?
Are you driving?
Me?
Yeah.
No, somebody else must be driving and isn't on mute.
Okay, fine.
It's not me. My washing machine's going off though, which is causing a bit of noise. Blood pressure is now raised from what it was previously, 133/88. She's now got a pulse of 111 as well. Respiration rate 18, SATs of 100%, and a temperature of 36.4. So again, that hasn't sort of changed at all. But this is at 03:30. So this is now sort of 8-9 hours post her initial abnormal CTG in our antenatal triage.
Sorry, Cara, just a quick question. Did anyone examine her and do a bedside scan?
Oh, good question.
Like,
Yeah.
did
Look,
we,
I've gone all,
is the
I've
baby
gone,
cephalic and did we examine?
Yeah,
I've
I was about
gone
to
all
ask
fancy
the
for
same
you
thing.
today, Maya. And I've
That's
added.
not fancy. That's basics.
No, I mean with my PowerPoint presentation, I was waiting for somebody to say it before I put it up on the screen. Yes, they did. This lady was transferred at 3:30, although for some very bizarre reason, the CTG wasn't started until 4:40. At 04:05, she was examined by the obstetric registrar on the night shift, and she was found to be 2 centimeters dilated, presenting part -2. And an ultrasound scan, bedside scan, was confirmed that the baby was cephalic. The plan was for a CTG review in 15 minutes, bloods to be taken, and to continue with her IV antibiotics. Plan now?
Again, I'm perplexed every time we come on the CTG meeting. There is the rule of review in 15 minutes and the rule of review in 10 minutes. And what is this 15 and 10 minutes going to do? I still want to understand.
I honestly think
agree.
It's a degree of uncertainty. So if you do not know what to do, then you think essentially when you come back in 15 minutes, you might have gained some clarity. So I wouldn't know it better. But sorry, my opinion about this trace. I previously thought it was abnormal and indicative of an infection. I am convinced that we are now having preterm rupture of membrane and an infection, and we're nowhere in labor. So the base rate has essentially is around about 150. There hasn't been any significant increase. We do see that the baby is responding to the uterine activity with increasing decelerations. And I would not start syntocinon on a scenario like this at all. So I think, if the function of the brain is reflected by variability. So if I either have absence of variability, if I have a zigzag pattern, which I may point out may only last for 1 or 2 minutes, or if I essentially have reduced variability, all of that is a sign that the baby's brain might be affected by this. I would be out.
So what's your plan, Dagmar?
I would have a kind of kind conversation with this kind of patient saying, like, we do not know much better at the moment. I might be kind of offering you a kind of intervention unnecessarily, but the reason why I would at the moment not proceed with labor is because in my opinion, you do have a preterm baby on board with ruptured membranes that already kind of is exposed to 1, 2, 3, 4 contractions every 5 minutes, and that is common in an infection because it causes irritation. If I try to kind of get you into labor, I can only increase the risk of hypoxia, and I have serious concerns that your baby might get more harmed if I do so, and I would therefore offer you an emergency cesarean section now.
I second that. I second that.
Yeah, I agree with Dagmar and Maya, but what I'm asking, who suggested Cinto? There is no Cinto suggestion. All the suggestion is coming back in 15 minutes.
I'm just kind of saying she's 2 centimeters. You can so what are the options? You can either wait, and give antibiotics, give fluids, but we still wouldn't have a normal variability because what antibiotics don't treat the baby, fluids don't treat the baby. So therefore, who am I treating here? So therefore, if I have abnormal variability, waiting is not an option. If I would like to get her into labor, then you would consider syntocinon. Would I start it on this trace? No, I wouldn't. So therefore, there's only one option left, which is for me to kind of consider a kind of a delivery. Given that she's only 2 centimeters, the only means that I have is a cesarean section, and that would be my rationale. But as I said, this is up to discussion. There's no agreement in this context. Yeah.
Yeah, I agree. I don't think there is any other options. There's no options of waiting 10 minutes or 15 minutes, as the Reg said. There is no option of anything except the CTG was, if even we are kind and say suspicious in the beginning, now it is abnormal with choreo, with the shrom, with everything, I think. And even if it is not, as you said, we don't know that with this deceleration, there is no need at all to stress this baby, and we are still 2 centimeters. So, yeah.
Perfect. The doctor review came at around 0440, and the impression that was made to this obstetric registrar was evolving chorioamnionitis. Terbutaline was actually given at 0442. And then the plan was made for a bolus of IV fluids over 2 hours. Sorry, not bolus, but IV Hartmann's to be given over 2 hours, and not for Kef and Met at this point.
But Cara, I think there's a little bit of predicted themselves at this stage. So we're saying developing choreo, then we give terbutaline. So how can you justify why did you give terbutaline? And Mr. Naguib, by the way, this is not my trace, but sometimes if I'm not sure or the trace is not sectionable, I do allow myself 10 minutes to go away and come back if it's not sectionable and I'm not kind of like the trace is really not there yet. especially in night circumstances, to make 100% sure I'm giving the right decision. So it's like when you're looking away and coming back. So that, I think that doesn't mean that registrar was thinking I'm going to ignore it or I'm waiting for it to improve, but more like interpersonal fresh eyes. It's like when you smell a perfume too much and then you kind of smell something else and then come back to appreciate it. So I think maybe that person was doing that just to kind of like see,
So
am I doing it correct in a night situation. I sometimes appreciate that they're might be tired or they just want to go away for 10 minutes and come back. But the tabitaline in this scenario, I really don't know what the justification for that is.
so
If you're
so Maya,
thinking developing choreo, not, I mean, sometimes it's very gray, like it's not sectionable trace yet, you're not happy. So to make that decision that I'm going to commit this lady so to choreo, because obviously here, yes, you are concerned enough that this is developing choreo, but then you are going to commit her without anything more than this to justify yourself. So yes, I agree.
so
I'm going, like,
mm,
I would section her at this stage of and time, but I would go away, close my eyes, and come back and look at it again and call it, rather than
yeah.
actually,
So
the,
so
I
just
don't,
to
yeah, just to kind of fresh my own eyes rather than do an hour or something like that. So you probably they're
yeah.
not waiting for anything to happen, a miracle, or for the antibiotic or the fluid. I think it's more like I'm giving myself another second look, so to go away and come back.
So I don't disagree with that concept. We discussed it before, Maya. Going, washing your face, and coming back. But my question to you, when you are on night and when you are doing this, and I have done it myself, I have gone and come back. I don't ever, after I leave the room, I write, I'll come back in 15 minutes. Then I come back in 15 minutes. Then I say, oh, I'm now sectioning. No, I do this second look, fresh eyeing myself, washing my face, rubbing my head, whatever you want to say, and come back and do it. Then I document one time rather than leaving the room. I'm coming in 15 minutes. It doesn't have any meaning to
Yeah,
to
true.
to, to
Very, very true. Yeah, I
so I
never.
d- I do it.
Yeah,
Yeah,
yeah, I know.
uh,
Anyway, I personally document things in retrospect. I'm not that smart
exactly.
on the ball. So I do document in retrospect most of the time. I'm not that efficient with kind of like documenting on the spot, but I think there's no other justification to what 10 minutes can do. I can't, I'm
No,
trying
there
to
is
read
one.
that person's mind. What are you expecting in 10 minutes to change?
No, there
Maybe,
is one justification. What Dagmar said. This person is not sure what to do, or there is something else here which happens to me and happens to you and happens to Dagmar and happens to every single obstetrician. There is two other traces going on. There is a section wanting to go to theater. There is an instrumental that needs to be done. So the only thing I can calm the situation or calm the staff of this room is to say, it's fine, I'm coming back in 15 minutes. It's not, this is not a plan. On in actual
true, true.
medical legal and in actual risk management, it is not a plan. It is rubbish. Then the second thing
Probably they
about
have like other traces to look at and prioritize
exactly,
who's going to theater first.
exactly,
So
exactly.
it's
So
maybe
that
that person wanted 10 minutes to think what they're doing management wise, rather than
exactly.
actually waiting for miracles on this particular trace.
Yes, but I wouldn't document it in this patient's notes that I am going for 15 minutes because me as a risk management person, seeing that this person is leaving this and coming in 15 minutes, I question myself. What does he or she want in 15 minutes? It doesn't make sense. So I will be criticizing this person. But if I say, I attended at so and so and so, and I looked at the CTG and I looked again, and it is so and so. And I personally, sometimes I give terbutaline, just to answer the point of terbutaline. I give terbutaline if I'm going to theater to allow myself to have spinal, because in Maybe I will not be exaggerating and say 9 out of 10, but 5 out of 10 of these CTGs, as soon as the anesthetist inserting his spinal, especially with their guideline now and the evidence and the papers that they have showed me over the last year that they don't preload the patients anymore because there is no evidence to preload, these babies collapse and have a prolonged bradycardia in prolonged deceleration, in theater, and I end up having to do it as a Cat 1. So if I am taking this specific one to theater, I want to calm these contractions till the anesthetist has the spinal put in, so I can proceed in a good time. But I don't give terbutaline and wait 15 minutes. So everything that is happening in this plan is contradicting each other.
But Mr. Naguib, I think terbutaline, this is not hypoxia, that's secondary. This is not hyperstimulation. So it's kind of
Even,
like, why are we
yeah,
giving it? Plus, number two, it's going to model
yeah.
your picture. Terbutaline in 5 to 10 minutes is going to raise your baseline. So you're going to actually be even more terrified of what's going on here. So
On the other hand,
if
no,
we're
no, it will,
suspecting choreo,
yeah,
what is terbutaline going to do?
to allow the anesthetist to put spinal. I am not giving
But
it and
then
staying in the room.
why not?
Maya, sorry, just kind of ask yourself, what makes contractions? It's essentially rapid fire 3 answers. It's bleeding, abruption makes a no, so abruption or blood makes irritation. Infection makes that, or essentially kind of a lot of labor, usually us with oxytocin.
Yeah.
Does terbutaline only work in one of the scenarios? The answer is no. It works in all of them because wherever you have essentially myometrial hyperactivity, it does work. It's contraindicated in abruption because it makes it potentially worse. It's not contraindicated in either of the others. So I would second Mr. Naguib that for as long as you're certain that you don't have an abruption, I would, with 1, 2, 3, 4, almost 5 decelerations in 10 minutes on a kind of very active uterus, knock them off. But I also would always ask myself, what is the cause for this? Because although or kind of tachysystole can occur in normal labor, we already have the suspicion. So therefore ask yourself, what is the cause? And if the cause is this is really early onset choreo, then ask yourself, are you going to achieve a normal delivery? And if not, then give the terbutaline and go to theater. And that is a difficult decision to make, right? You're an ST7, Mr. Naguib has been a consultant for a long period of time, and so have I, but I do believe we shouldn't judge. So this is for education purposes. And I therefore think the exchange is the important bit, but not the judgment of the person.
I don't think there's judgment, Dagmar. I'm just saying what I think I would have done. There's no judgment here.
No. I'm just kind of saying, I think we're assuming what the person might have thought or not thought. And so therefore it's not ours to know. But
I'm asking Mr. Naguib like why he would give terbutaline if we're thinking we're all agreeing this is choreo.
And that is essentially the rationale that I would have. I just gave you because for either kind of choreo or kind of uterine activity, or it might also kind of work, and you also have increased contractions if you have platelet consumption and severe preeclampsia. So that was another one, but I will sum that up under bleeding. Terbutaline might work. So therefore, if you would like to resuscitate the baby in utero, which is what it's for, in order to kind of make then therefore the remainder of the delivery safer, then it's a fair drug to give, even if you're in theater, for as long as you're aware, A, what is the antidote, and B, kind of be prepared for PPH. Which is not, as we know, more common, but you still need to kind of be aware of that. So therefore give terbutaline and then know why and what your next plan is.
Perfect. Any additional comments, anybody? Okay, so Hartman's is commenced at 05:15. And then at 05:37, the position of the woman is changed, I believe, to left lateral due to those decelerations.
Now I would, as midwife, ask where the kind of review is.
Where the review is?
Yeah, did the registrar not say coming back in 15 minutes? This is now half an hour. More than that, actually 15 minutes.
Yeah, so there was no sort of plan made here. I think the plan was just to continue with the fluids and then essentially see if that made a difference, maybe.
I would always ask, what are you treating with fluids?
Yeah. Although it may have been for a reason, sort of, if they thought that mum was maybe dehydrated or something, although that's not documented anywhere. But also what I wanted to add here is the fact that if we've got a CTG that we're concerned about to the point where we've given Tabuterin, we also need to be doing some more frequent maternal observations. And in this case, all of the observations that were recorded are the ones that I've included in my slides. So just as a sort of side note, specifically with Tabuterin as well, this woman's got no epidural on board. So I think sometimes we forget that, you know, when we've got an epidural on board, we do observations really super regularly. But we also need to be doing them more regularly for other things other than just having an epidural as a risk factor. Because I'm finding very frequently at the moment that we are maybe not performing our maternal observations as frequently as we need to. Specifically, for example, if women are having a tachycardic one moment and then the next moment, then we don't figure out how long it is in between two sets of maternal obs, whereas actually we need to be a bit more cautious of our sort of Muse charts and whatnot. So at 05:47, she goes out to the toilet, and then at 05:55, the registrar comes into the room to review, examines her and finds the cervix to be 3 centimeters dilated. What's our plan?
I think that is a difficult question to answer, given that at least 3 of us essentially would have offered a cesarean section. So if I thought I was in the position of the registrar, I do believe that would now be progress, because I think the first examination was at 4:10. It was 2 centimeters. This is 3. She's still contracting 1, 2, 3, 4. Yeah, about 4 and 10. So I assume, and there's no rise in base rate, which happens with the Tabuterin if there's more adrenergic impetus, then you essentially kind of block with the beta blocker. So I hope I make sense. So then with the adrenergic drug. So sorry about that. Yeah. So anyhow, so the I would assume that they probably kind of proceed, but I would still ask, if you're having 4 contractions in 10 now, how long does salbutamol last, or Tabuterin? It's about 1 to 2 hours. The tachycardia normally subsides about 30 minutes after administration. So do you think you would then be giving the Tabuterin again in approximately 1 to 2 hours? Because there's no reason, why the kind of contractions wouldn't perk up again. If you have a lot of contractions in the first stage, think about the second stage. You will have a subacute hypoxia, almost guaranteed. So I stand by none of these thoughts make me wish to continue. I would continue to bail out.
Perfect, thank you. So position has changed to left lateral. We've now got a rise in baseline sort of closer to 160 now. Position has changed to left lateral. And at 6:15, the client reports feeling pressure and is started to involuntary push. So the midwife then examines her at 06:30, finds her to be 6 centimetres dilated, fully effaced with a presenting part at -2. I believe baby was in a good position. I'm assuming we're all still of the same opinion. Okay.
Yeah, we are still, yeah.
Still of the same opinion, although at 06:53, she was re-examined again, fully dilated, vertex was visible with pushing, so active pushing was commenced, and a male infant was delivered at 07:08.
I can't tell you how
So still
relieved I am. I can't tell you how relieved I am that she labored incredibly fast, and that the kind of bit of subacute was, you know, with all of this loss of contact, difficult to kind of judge, but definitely it looks only about maybe 10 minutes, maybe 20, but not more than that. I still believe that this. I hope, because choreo is so difficult to judge. And babies essentially, and the variability looks awful in the kind of bits that I can see here. I would still think that this baby probably needed some resuscitation, and had some respiratory issues that they very often have if I have a kind of choreo, and essentially was a NICU, but I hope nothing else.
Anybody else want to have a guess?
So I would, before we guess, I think we had a lucky escape here, and I just want to say that few cases were shown to me down the line of 10 and 15 years to talk with the risk team about that there is a claim, and the claim is that the child, or now the teenage, has hearing problem from the beginning, and have eyesight problems, and have. And when you look at the CTG and look how it's awful, and then they have a vaginal delivery and the upguards are fine and so on, it was a lucky escape at the time. But inadvertently, as Dagmar said, we don't know how the neurological efficiency in this brain will develop in the future. So it's a lucky escape that we went from 2 to 6 to fully, but it doesn't, give us a full justification that it was the correct management. Vaginal delivery is not always the correct management or the correct answer. We were lucky, and we hope, we pray.
I honestly cannot judge if we were lucky or not. I have seen HIE 3s with infection. So I mean, I know it's kind of a hypoxic ischemic event, which is not, but it's essentially equivalent. So the variability is poor here. It really is. And there's a little bit of hypoxia on top. I have no idea how good the reserves of this baby were preterm. So I hope we got away.
So this baby was born with APGARs of 9, 10, and 10. Birth weight 2645 grams on the 53rd centile. pHs were within normal range. I think this was probably, well, actually, no, the base excess is very different, isn't it? But arterial pH is 7.38, base excess -2.1, and lactate of 2.8. Venous pH 7.37, base excessive -1.7, and a lactate of 2.7.
I'm certain that they are the same. So by medical legally, you need the arterial and venous pH
0.03.
Correct difference. Otherwise, you have the same sample. Given that it's more difficult to kind of sample the arterial, it's very likely venous. So given that you have no arterial, you have no idea about the kind of degree of hypoxia. Given that the APGARs essentially are, well, as Mr. Naguib said, really lucky escape, and I'm grateful that she was so fast. I didn't feel comfortable with the CTG at all.
Perfect. Does anybody want to add anything?
I just would like to say that from the midwifery point of view, I feel for the midwife who was looking after the woman, and maybe even the coordinator, because just like Mr. Naguib said and Dagmar, I would just have gone with them, like we need to prepare to go to theater, and maybe I would have even been preparing my bits and bobs to go to theater, and I would have felt very disappointed about the whole night, as from the midwifery point of view.
Thanks,
May I
Beatrice.
ask what escalation tools you're using, Beatrice? Because I do believe none of us should be kind of leaving work utterly unhappy, and feeling unheard.
So I don't know the documentation of what was happening, but putting myself in the shoes of the midwife, I think she was put in a difficult situation.
I mean, there's not really any reported escalation on the notes with this. So a plan was made. The CTG was always very much abnormal for antenatal, and then became more suspicious when we sort of transitioned into the labouring phase. This wasn't a case of a midwife was escalating their concerns and having to sit on it. So I think from an empathetic perspective, I think that's great, and we should definitely be doing that with every single case, thinking about all the clinicians. However, this isn't one where a midwife was sat in a room necessarily concerned for a prolonged period and not feeling like they could say anything.
Yeah, I'm saying that the midwife was not in a position that she was not saying anything. The doctors were coming, but the clear picture of that MDT discussion, like when the doctor said, I'll come in 15 minutes. During those 15 minutes, what was the thought process of the midwife? Another 15, half an hour, another 1 hour until the baby is born. That's what I'm talking about.
Okay. Does anybody have anything else they want to add?
No, thank you very much. It is very nice presentation and very nice case for debate. And I think lots of debate happened, and that's very healthy.
Thank you, Mr. Naguib.
Thank you very much. Thank you.
Thanks, everybody.
Thank you.
Thank you.
For everybody who